So we'll take our second speaker first, Dr. Ramesh Babu BOBBILI, and tips and tricks for better outcomes in toric IOLs.
Mics. Switch on the mics. Okay, fine. Shall I start, sir? Yes. Yeah. Good evening, everyone. I thank AIOS for giving this opportunity. I'll be talking on tips and tricks to achieve better results for toric IOLs. I don't have any financial interest. Quality of the vision is poor in the case of astigmatism in the bright light as well as dim light. They see lots of contrast and data blurring and ghosting of images. If you don't treat these patients with toric IOLs, means you're losing significant amount of income by these patients because prevalence of astigmatism in these cataract patient is more than 1 to 1.5 is 18% and more than 1.5 is like 22%. So by improving the quality of the vision to them, we can improve the satisfaction rates. To understand this one, we need to understand about SIA, keratometry, IOL formulae and toric calculator. Keratometry, always better to use automated, and newer ones like topographers or optical biometers. If you include these keratometry readings for SIA calculation, that will give better results. SIA calculator, we use Warren Hill SIA calculator online because SIA influence the refractive outcome. Mainly width is the main factor for this one. We need to know about these incisions, how much they induce astigmatism. That we need to know, and we need to know the mean, median and centroid. For this one I will be showing these are the values we need to enter: right eye or left eye, date of surgery, age and incision location, and type of incision and incision size we need to calculate, and we need to enter the data, and we can enter any comments also. We can save by saving this one. We will be knowing the astigmatism status like this. You can see all the astigmatism y axis and x axis, total SIA it will come, and we can see the reports. If you get a decent amount of data, I am now looking for 2.8 mm incisions. This is the left eye, this is the right eye. The mean, it's coming for mean values are coming for left eye, it's 0.59 and 0.45 for the right eye. In the median, it's 0.5 for left eye and 0.28 for right eye. The incision size entered here is 2.8. And centroid, these values are important, especially if we are using Barrett IOL calculator or Alcon toric calculator. We need to enter these values. For 2.88 incision, I am getting SI of 0.16 in the case of left eye and 0.08 in the case of right eye. Whereas you need to know about this one. Whereas coming to 2.2 incision, there are 32 matching records. I am getting more astigmatism when compared with 2.8. Only small incisions work better in very soft cataracts. Otherwise, you will get more amount of astigmatism when compared with 2.8. You need to remember while calculating SIA, while planning for cataract surgery. So coming to IOL formulas, as you know, within the normal axial length, all of these formulas work very well. Extremes of axial length, most preferred one nowadays is Barrett 2. Toric IOL calculator, we can, with the IOL formula, we can calculate the spherical power. But if you use APRSA calculator, online calculator, we can get IOL power also. So I always calculate APRSA latest one, toric calculator version 2 of Barrett. So that will give spherical power as well as the this one. Toric calculation also it will do. We need to enter the keratometry values. If you don't have an instrument which can't measure PCA, then we can tick predicted PCA. Otherwise, if you have an instrument which can predict the posterior corneal astigmatism, you can enter the values from this one. See, this is how it shows. The eye, we need to select predicted PCA. If you have any instrument which can measure PCA, you can enter that one, and you can enter the data like this. Then you can get a printout like this. Here it's chosen T4 lens of 18.5 lens. For optimum results, I prefer minus 0.35 spherical equivalent residual in these cases. So the simplest way I do is in this manner. I preoperatively mark intended axis. I don't usually make horizontal. I directly mark the intended axis for the IOL implantation. After putting the paracrine, we need to ask the patient to look into the slit lamp beam. After putting paracrine, after drying the conjunctiva, we can mark nasal side and temporal side. And everybody has, we don't need to use high-end equipment, markerless systems. Simple smartphone app which have a gyroscope. Everybody has nowadays simple phones everywhere. So we can use, for iPhone, we can use a Toricam app. We can use, this is developed by Graham Barrett, and we can, after marking, we can verify the accuracy of the axis. We can take the photograph, and after placing the lens, we can compare, and we can rotate the IOL accordingly. For the Android, we have different apps like iToric and Crystal Toric. There are many apps. We can, everything works very well. Every app works very well. So you can depend on these things. No need for high-end equipment like this one. This is how surgery is being done. This is a high-Q toric lens. This is a horizontally I am giving an incision. Side port is made, then the capsule is stained with trypan blue. Chamber is filled with viscoelastic. Now capsular access is being done with the bent 62 needle. I usually aim for 5 to 5.5 mm rexis in these cases, all toric cases. There was a tendency because of viscoelastic, there was a tendency to extend periphery. We should, in these lenses, especially torics and multifocal, rexis should not go run away. So hydrodissection is done, and by flip and chop maneuver, phacoemulsification is being done. We need to protect the endothelium sufficiently so that endothelium, we can protect the endothelium well with help of dispersive viscoelastic. Cortical aspiration is being done with coaxial IA. Then the IOL is IQ toric is now will be implanted. First, we need to this one is implanted into the bag. Now the viscoelastic removal just 2 clock hours shorter than the required placement. We need to remove. We need to place the lens. This is the horizontal axis. This one is the intended axis here. After removing the viscoelastic from anterior and behind the IOL, then the IOL is rotated to the required position. This viscoelastic is removing from the behind the IOL. Now you can see the lens is, yeah, it's done. So we need to make sure that chamber is watertight. Any loss of the any loss of fluid that can cause shallow of the chamber, that can again rotate the lens, then it will alter the results. This surgery was done way back in 2013. This was the result. If there is any change in the lens position, again we can fix that one by using stigmagenfix.com. Thank you for your kind attention. Any questions are welcome.
I just want to add one thing, very good tips, because these are some things on the Barrett calculator which we don't look at, but you can take something which is there on the calculator called an integrated case. So you may want to look at the toricity of the cornea with maybe more than one machine. So they give a mean as well as a median.
We can enter many values in that one. That has an advantage.
Maybe just add 3, it gives a median.
Yes.
If you add 2, you get a mean. It's a good idea to look at the median, and that may give you a different axis from what you were expecting.
Yes. There is an advantage of Barrett toric calculator.
I didn't get how 2.2 is causing more astigmatism than a 2.8 incision.
Obviously, it is causing more thermal damage to the wound.
You're saying there are corneal wound burns.
Yeah, there are many people say that one. I don't know. They won't say in public. They have noticed. Few people have noticed. In my study, I got clearly. So nowadays, I don't do torics with 2.2 incision.
But that would depend on the tip that we are using. If we are making a 2.2 incision, then our tip would vary as compared to a 2.8 incision. The idea is that we need to have a watertight incision without any leak, and if it's wound burn happens typically when we use a lot of energy.
Not clearly the burn actually. There will be some subclinical damage might be there.